Welcome to Neuro Stories, the podcast that highlights the people behind neuroscience at the Walton Centre. Together, we'll lift the lid on the complex worlds of neurology, neurosurgery, and everything in between, hearing fascinating tales of the incredible staff and services carried out in the hospital every day. No, don't worry. I appreciate you're in a meeting. Yeah, it's okay.
Hi, I'm Saif Huda. I'm a consultant neurologist at the Walton Centre.
So, Saif, tell me about your specialism.
As well as being a general neurologist, we also tend to subspecialise in various areas, which we try to become expert in and try to help. So there's, of course, the bread and butter of neurology is the sort of things that you would expect a neurologist to see, sort of headaches and trapped nerves and that sort of thing. But within the field of neurology, there are lots of subspecialties. So there's things like dementias, there's multiple sclerosis, which is what I specialise in, along with autoimmune disorders. So normally our bodies are really good at protecting us from viruses and infections, and then they battle against that. But sometimes the body misdirects that defence against itself, and in particular when that affects the brain, the spinal cord, nerves and muscles, that can result in neurological syndromes, and they can come about as a result of antibodies, and that's what I specialise in. So autoantibody mediated neurological conditions.
So quite specific, but then also you're a bit of a master of a few different things there, aren't you?
Well, that's very kind of you to say, a master, but we're always striving to do that. I think at the moment you think that you're at the top level, then you're losing. You need to always be striving to be better, to get to that master status, but I don't think you ever reach it, but it's kind of you to say. But yeah, we have to be able to deal with a wide variety of different things. And it's something I didn't realize when I was doing general medicine, deciding between medicine and surgery, and then I was deciding what I wanted to do in medicine. I thought, well, I'll be a neurologist and I'll be that. And then you realize within neurology, there's so many different subspecialties within that. And then within that subspecialty, there's so many things that you use to help you. So for instance, people who do muscle diseases have to be very good at looking at muscle biopsies and looking at the slides and the pathology, but also the electrical studies that look at how the nerves and muscles communicate with each other. So you have to be not just good at the clinical stuff, but also good at the sciencey stuff that goes with that. For what I do, the antibody mediated stuff, I have to be quite au fait with the laboratory testing and how we do that and what the limitations of that are, but also MRI, because that helps us to determine what the conditions are. And there's some other things that we use to help us. So that's why we think of neurology as a neuroscience, because we're blending together the science and the clinical together seamlessly to be able to do the best for our patients.
You're doing that sometimes with a short amount of time to see a patient, and each patient is different. Combining that wealth of knowledge that you've accrued over the years, over your training and also your experience as a doctor, but also trying to think on your feet and think around a problem.
Yeah, I think that's one of the privileges that we have of doing what we do. Because I always, having been a patient, as we all are at some point in our lives, we go and see our GPs, and you realize that you're telling people quite personal stuff, and you have to engage with someone you don't know very well. And that's, when someone comes to see me, I'm very cognizant and aware that they're telling me their deepest and darkest secrets very quickly, things they wouldn't tell sometimes their loved ones, things that they're embarrassed about. And you have to engage and get that rapport quite quickly. But then you want them to feel comfortable at ease, but you also need to be able to help them to help you figure out what the issue is. And some of it's pattern recognition, some of it's instinct, some of it's using the examination and all those things that we've learned over the years. And even when we get to the end of the consultation, we don't always know what's going on. And in some cases, we don't find out what's going on, but we do our best to do that with additional tests. But it can take several months, even years, to make a diagnosis. And helping patients through that journey is particularly important and very difficult and challenging for some. So it's not just about, being a Sherlock Holmes, which is what I love with neurology. It's also about, helping patients through that process of trying to figure out what the diagnosis is.
Yeah. Why medicine for you?
I was going to think about how I was going to answer this, because I knew you'd ask me this. I didn't really have my heart set on medicine when I was doing my GCSEs and my A-levels. I was actually more interested in the arts and history and French, and that's probably where I excelled more so in terms of, I think I probably had more ability with that. But I was really unimaginative. But both my parents are doctors, and they've been saying to me from a young age, you're going to be a doctor when you grow up. And I was like, no, I'm never going to be a doctor. Forget about it. And it got to the point where I was choosing my A-levels, and I thought, well, if I do history and English and French, I was like, I don't know what I'm going to do with that. I don't know what job I'm going to have at the end of that. And of course, clearly the brainwashing worked, because I could only think that, well, I better choose something that I'm going to get a job at the end of it. I chose science and maths A-levels, and then applied to university, applied to come to Liverpool, and applied amongst some other London offers that I got as well, but I chose Liverpool. Even in the first 2 years, I wasn't really convinced that it was for me. I was ready to jump ship and move to something else.
Really?
But it was the moment that we went into a hospital and started talking to patients, and then suddenly all the stuff that I'd been reading was put into context of it, that it really became tangible. It made me realize what this was all about. And I think I needed to experience that firsthand. And I think from day one I was hooked. I'd suddenly gone from someone who actually wasn't that enthusiastic, and I was just in all the time in my extra time. I was in the acute medical unit at the Old Royal, and I'd just spend hours there just absorbing, just being in the environment. There were some consultants there who were really good diagnosticians, and it was just, I don't know, it's probably a bit of an old reference now, but there's a show called House MD.
Yeah.
And it was all that sort of trying to put it together and figure out what was going on. It would seem like that's what they were doing. And that just got me hooked. I really love the idea of trying to figure out a problem, trying to solve something, mastering, if you can ever master things, taking bloods, putting in central lines, putting in chest drains, so making people better. But I still didn't know if I was going to do medicine or surgery. Even the day before I put in my applications for medicine, I was still tossing up between doing surgery. And similarly, the day before I put in my neurology application, I was still considering doing gastroenterology. So I've very much kept my options open as I've gone along, and tried to experience firsthand what it is that I think I want to do before I commit to that.
Because obviously it's a gamble, isn't it? You're trying to set up your future. You're trying to make sure you go into a part of medicine that you're going to enjoy for your whole career. So there is, I can appreciate, I would be the same, going, should I or shouldn't I?
Yeah, and I get that we need to streamline training and get more consultants and get more expertise, and that's important, of course, but you don't want people who are in it for the wrong reasons. It's hard, as you put it very nicely, like, how do you know that's going to be the thing that you do for the rest of your life when you're 21, 22, or if you're 17, 18, you're like, this is what I'm going to be. And then you get there and you realize, well, actually, this wasn't for me. So I think it's important to have the opportunity to try something and then decide if that isn't for me, then you've got an exit strategy that you can move into something else. But at the same time, if you want to commit to it and you only realize that after, you still have the ability to be successful at that, and you're not penalized for not being ultra driven in terms of knowing what you're going to do on day one. Also, what we do as early on in a career is just totally different to what we do as a consultant. So what I did as an SHO or registrar, which are the sort of more junior, sort of senior resident levels in the American system, is totally different to what I do now as a consultant. So how was I to know what that would be? Of course, you can shadow people, you can get a sense of it, but you never really know it until you do it.
Looking at your work here, what are those motivators for you?
There are a lot of things. I love what I do. I think there are times when I don't, whereas we all have those days where you think, gosh, I wish I was doing something else. But, I do love what I do, and I couldn't see myself doing anything else. I think it's largely about the people that you work with, the teams that you work within, knowing that there's a shared objective that you're working towards. So I'm very fortunate in that I lead a team of highly motivated individuals, and I've recruited a few of them myself. So I have a vested interest in bringing them on and developing them. And so I have consultants coming from around the world to train on my team, which is a wonderful thing. And you see how they progress. And I've got, highly specialized nurses that are just phenomenal, and seeing how they progress and seeing, their development and what they can do compared to what we were doing 3 years ago, to what we do even 6 months ago. That's hugely inspiring for me to keep me moving forwards, but also what we do in our clinical jobs. So patients with autoimmune conditions can often present quite dramatically with aggressive visual loss. They can become blind, they can become paralyzed very quickly, and the therapies that we give, because it's such a responsive condition, we can reverse that. We can make people blind see again. We can make people in wheelchairs walk again, which is really nice. And there was this sort of historical feeling that neurologists, they sit around, they scratch their beards and twiddle their bow ties and readjust their glasses, and then they think, oh, well, it's this very rare diagnosis, but there's nothing we can do about it now that we've made it. We've moved on a lot from then, and now there are loads of things that we can do. I think it's one of the fastest moving and developing specialities in all of medicine. If you take stroke, for instance, where we pull out clots. People give clot busting drugs, or they're called thrombolytics. And when that doesn't work, when one of the large vessels that supplies the brain is blocked by a big clot, when the clot busting drug doesn't work, we can go in and take that clot out. The effectiveness of that therapy is the most effective of all medical therapy. So we're talking about every medicine you can think of them all, that is the most effective strategy. And that is within the remit of neurology. So
staggering, isn't it, that?
How privileged is it to be a part of that?
And what a great example as well, because obviously the Walton Centre is one of those centres that does perform thrombectomies.
And to be involved with that when you're on call is fantastic. You know, you're at the tip of the spear, really, trying to make people better, and that's just incredible. And you see it. The patient comes in and they are completely paralysed on one side, they can't see, and then they wake up, and within hours they are starting to recover.
Yeah,
pretty amazing to be a part of that.
Obviously, I know that sometimes research and your work can take years, but what is on your kind of work bucket list for this year? What are you looking to ticking off?
There's a lot. For the past 5 years, I've been doing research in my free time. So I do a sort of 100% clinical job and try to fit in the research around that. And that's gone very well. But as things go well, the work increases and it's become sort of less easy to juggle both. Ultimately, you do have to sacrifice a bit of time, personal time to do that. And that is challenging. So I was very fortunate to win a grant recently that allows me to have some protected time. And the Walton Centre has been incredibly supportive with that. And so that allows me now to do research as part of my day job, which is just revolutionizes things for me, because the 5 a.m. starts and the 1 a.m. emails catches up with you after a while. So now that I have that, I have great visions about what we want to do. We want to really put neurology on the map for the Northwest, and we're building up great collaborations both nationally and internationally. But we really want to get a better feel for what's driving these conditions and how we can treat them, but not just in the way that we've traditionally done it with sort of immune suppressant drugs, which are pretty blunt instruments. They just blunt every part of the immune system.
Right.
We want to be much more targeted and precise, so we understand exactly what makes an autoimmune disease tick, and then we find its Achilles heel, we modulate that, we manipulate that, and then we have a targeted way of rebooting the immune system in a way, or modulating it in a way that we don't do it to the detriment of opportunistic infections, which is a big problem. That's what a lot of my research focuses on, along with clinical projects that we do, but also big data where we're looking at epidemiological data to try and understand better what the impact of COVID has been on certain autoimmune conditions, how things have changed over many years. And then also, again, it's about teams, about working with the right people. No man is an island, no person is an island, I should say. And so you work with great people. So I work with people at the university who are involved with imaging, with epidemiology, with basic wet lab stuff. You try and put that together into a cohesive project, the end product of which you hope changes what we understand about that condition. Because ultimately, as a clinical neurologist, I can hopefully positively affect one patient at a time that I see. But if you answer a question in research about a condition, you can potentially impact every single patient with that condition by answering that question and change everything, create a paradigm shift. And that's what we always strive for, is to make. And it's about giving back to the specialty that has given me so much. So that's what I try and do. That's what I aspire to do.
We're going to do the quick fire round. Are you ready?
Fire away.
What would you be if you weren't a neurologist?
Well, I'll tell you what I wanted to be. I wanted to be an Air Force pilot, but
Maverick.
I wanted to be Maverick. That's exactly right. So my uncle was he was the sort of highest Air Force Commodore in the Bangladeshi Air Force, and I always thought he was going to hook me up with the job when I was a kid.
That's so cool.
But I didn't have 20/20 vision, and you kind of needed it then, so it never really panned out. My days flying F-14 Tomcats were never to be.
What's your biggest hobby?
Exercise and playing tennis. Yeah, I'm quite a exercise junkie.
Favorite book?
There's so there's a guy called Andy Weir, and he wrote The Martian, the film that was Matt Damon was in.
Oh, Stranded Out There.
That's right. Yeah. So I love it because it blends a bit of nerdy science with just a bit of Hollywood jazz.
Blockbuster survival.
Yeah, but it's got quite a good bit of humour. And he's done another book which I really love called Hail Mary, which I think is even better than The Martian.
Oh, right.
And that's a fantastic book. So I really love those two.
Add that to the list. Favourite film?
Usual Suspects. I think it's just very extremely clever the way that the film is shot, the way that the story unfolds, and then obviously the clangor at the end.
Favourite animal?
Whenever we go to Chester Zoo, I always like to see the snow leopards. They're a new addition to Chester Zoo now. We've enjoyed seeing the snow leopard.
Food you love?
I think probably just Thai food. I love Thai food.
Yeah.
And it also invokes lots of memories of travelling around that part when I was a student.
Food you hate?
Brussels sprouts, like every other person.
Classic.
Who likes Brussels? What are they for, really?
What advice would you give to your younger self?
Take a gap year to grow up a bit, be a bit more mature before you go to university, because you've probably got more academic mileage out of it. But I probably could have worked a little bit harder.
Got you.
I don't think anyone would disagree with that who knows me.
What's the best thing to happen to you?
That's got to be my wife Catherine and my kids.
Who's your hero?
That's a tough question, because it depends on what walk of life you're thinking of. If you're thinking about what I do in my work, there are various people who I hold in very high regard. If you think about driving to achieve and trying to get somewhere and just grafting and never giving in, and that sort of attitude, David Goggins is like, I love that book. In fact, that has to go on one of my top books. The Can't Hurt Me Now biography that he did is just phenomenal. I really love that. I love his mentality about how he does things. And then obviously, there's my parents in terms of what they went through. They left during the Bangladesh Independence War. There's a lot of strife and violence, and they escaped and came to this country to work.
Wow.
Times were tough at that time for their background, without elaborating too much on that. But I think that to achieve what they achieved, and to give me the opportunities that my sister and I had, my dad was up at 4 a.m. studying. He finished top 10 in his boards in the entire country for his exams.
Wow.
I try not to think of it because it's pretty daunting in terms of the caliber of the family you come from. You try to match that and not disappoint. And then they would never say that, but you think about it. So I think in terms of what they've accomplished, what they've achieved, and for us is huge. I don't really tell them that enough.
Something very few people know about you.
I'm a big fan of chasing status.
How has your subject area changed then over the years, over your career, would you say?
So I think that autoimmune neurology was very, very limited 20 years ago, and it's just exploded in the past 2 decades. We've just discovered antibody after antibody that's been responsible for conditions that we've never really had an explanation for. So it's allowed us to characterize things a lot better, where it be encephalitis, myasthenia gravis. So encephalitis, we typically think of it as like an infective thing that causes inflammation in the brain, seizures and behavioral change, but we know that can be autoimmune driven. And then myasthenia, which causes weakness caused by antibodies. We've discovered new antibodies with that. And in the field that I work in very heavily, which is central nervous system inflammation that's not caused by MS, well, we've discovered a lot with that too, not just in terms of what drives it, but also the therapeutics that we can use for it too. And that's the conditions that we were talking about: Neuro Myelitis Optica, spectrum disorder, but also MOG, antibody disease. And there are new ones that are going to be popping up in the next few years, I'm sure. So I think that we'll start to see more and more of those antibodies. How relevant they are to the ground population of these conditions, how much they account for, it might be 1 or 2%. But and we can say, well, what is the importance of that? Well, that's a person, that's a patient, that 1 or 2%. And if that helps us to know a specific therapy, well, that's important. And you can learn a lot by looking at rare diseases. You can extrapolate that to common diseases. So it is important to look at these. And then we've definitely gained a lot from looking at that. Certainly some of the therapies we use in NMO have been derived from other conditions with similar mechanisms of action in the hematology sphere, for instance. So we're constantly extrapolating and learning from cross specialities and other neurological diseases.
And part of research is ruling out those areas that have been previously undiscovered so that they're not raked over again, isn't it?
Yeah, but at the same time, it's important to rake over those areas again. So one great example is MOG, which is responsible for a lot of non-MS CNS inflammation, central nervous system inflammation.
What does MOG stand for, sorry?
It's a bit of a mouthful. It's myelin oligodendrocyte glycoprotein. So if you imagine you've got your it's
well done.
You've got your nerves, and you've got the insulation around them. So it's like your wire and your insulation, your electrical wire and the insulation around it. Well, myelin is that insulation, and MOG is like 0.05% protein, that insulation sheath. So it's remarkable how such a tiny thing that we actually don't really know what it does could account for such a large proportion of people who have recurrent inflammation of their eye or their spinal cord.
Right.
But again, it's something that had a very checkered past 20, 30 years ago because of the types of ways it was being detected, what we call assays. They weren't necessarily the best way of doing it. And so we were detecting it in a lot of conditions where it was just false positive. So in healthy people, we were detecting it, and people thought, well, this is a load of rubbish, we shouldn't even be looking at MOG.
I see.
And then it was re-raked over, and then we realized, actually, if you do it in the right way, you can pick out patients. Suddenly there's a whole new disease that we've defined.
Wow.
Because people went back and looked at it again.
Right. So ignore what I just said.
So no, but absolutely, it's important to do things. But as technology moves on, it's always worth revisiting things as well. But absolutely important to make sure that you define what the negatives are. And I think as a researcher, we always have to think in that way, that nothing is ever certain. Always consider the possibility that it could be something, and then try and prove it. Try and prove it as a positive, and then try and prove the negative as well. And then you have more robustness to your hypothesis.
Yeah. Where's the subject area headed for you? Where do you want it to head?
Well, I think the biggest strides that have been made are the therapeutics. So NMO, Neuro Myelitis Optica, previously thought about it as a very severe version of multiple sclerosis. But now when we discovered the antibody, we knew actually it's something completely separate. It has its own diagnostic criteria.
Wow. Just
like MOGAD now, MOG antibody disease has its own diagnostic criteria as of last year. And we'll see further break-offs from things that we didn't...
These branches of branches
exactly.
that you're talking about.
It is exactly. It's the branching out and further subclassifications. We understand it better. But by understanding it better, we know that some multiple sclerosis therapies make NMO much worse. So it's important to branch these patients off and understand what they have. But consider a disease that is ultra rare, approximately 1 in a million in the UK. It's slightly higher depending on where you are geographically. In the span of 20 years, we've been able to do about 3 or 4 randomized controlled trials that have all been positive and led to approved therapies for this disease condition is simply phenomenal. To be able to get the international collaboration to do that for a 1 in a million condition.
Wow.
And bring that together in a cohesive trial that is positive. And that stems from the basic science of what we understood about how it works and unpicking that, and then finding the therapies that work, to now people having approved therapies that they can use for the condition. And we're working on access for those in the UK currently. That usually takes 70, 80. When you look back at other conditions when they're first discovered, it takes decades for them to get approved therapies. It's been ridiculously fast in NMO, and I hope it will be the same for MOGAD. And we see that with other autoimmune conditions too. So myasthenia gravis, something I did my PhD in, when I was doing that, there really were no approved disease-specific therapies. We were just recycling drugs from other conditions and then using that in myasthenia. But in the past 2 or 3 years, we've seen now, not 1, but 2, but 3, but 4 new drugs coming through the pipeline in controlled trials and accessible on the NHS now as well. Right. Therapeutics are a huge push in autoimmune disease, and there's a lot of interest from pharmaceutical companies about that, which is wonderful.
We have a wide range of people listening to the podcast. What kind of takeaways do you want them to take away from hearing you speak on this episode?
I think that neurology, we can make it sound really complicated, but at the end of the day, you can always make it really simple. And I think of myself as a simple person, and I think that things need to be broken down very easily. And if someone isn't explaining it to you in a way you understand, that is not on the person who's listening. It's on the person who's explaining it to know it better, to be able to explain it better. And I think that if there are people who are thinking about doing neurology or medicine or anything like that, I wouldn't want them to be put off by the more niche things that I've been talking about, because we can overcomplicate anything and make it sound really, clever and all the rest of it. But ultimately it boils down to the body's attacking itself. We just need to sort that out. Or, whatever the condition is, we can break it down to first principles and, understand it. So I think that I would want people to see the speciality as something that's accessible, that we are, regular people just like anybody else, and we're trying to do some good here and trying to treat our patients and make people better. And the more interest there is in that from all parties, public, government, etc., the more we'll be able to facilitate that occurring. So I just want to enthuse people with the idea that this is a really cool thing, to be a part of. And you don't have to be a doctor to be a part of that. There's so many ways to get involved in neurology, whether it's advocacy groups or charities or, supporting people who who may have a neurological condition. But a lot of people know people with MS. It's super common. Most common cause of acquired neurodisability in young people, in fact. So just supporting that, MND, the Ice Bucket Challenge, that sort of thing, that was huge for public knowledge about it. And sadly, we see a lot of sports people passing away from that conditions, but they do such good work to raise knowledge and awareness of those conditions, and that leads to funding and that leads to more breakthroughs. So I think don't see it as a sort of something that isn't accessible.
Thanks for listening to Neuro Stories. You can listen to more episodes on Spotify and Apple Podcasts, and you can stay up to date with the latest news and events from the hospital on our social media channels, at the Walton Centre on Facebook and Instagram, and at Walton Centre on X. If you've got any feedback, email the communications team at wcft.communications@nhs.net. This podcast was recorded, edited and hosted by Sam Fleet from the Walton Centre's communications team.